welcome. The information in today's podcast is for educational purposes and does not constitute legal, clinical, or financial advice. Listeners should consult qualified counsel and licensed professionals for guidance specific to your organization and jurisdiction. Here I cite primary sources, but also scholarly peer-reviewed journal article literature where available, and I try to share that information with you guys. All right, so welcome back to Roots of Resilience. Strengthen your foundation, thrive in adversity. I'm Dr. Tarina Knight. I'm a doctor of behavioral health, integrated behavioral health care leader, and I specialize in Lean Six Sigma. I'm here today. You guys know I've been doing this podcasting now for over a year. My numbers are still low, and that is fine. I'm okay with that. I reach who I reach, how I reach, and hopefully you guys can learn that inconsistency means the best leader. Best leadership is always inconsistent because they know that sticking to one path is like the greatest level and setup. It sets you up for failure because you're stuck in just one way. Look at things from multiple lenses and you can be successful. So come join in my podcast, come visit me, come listen, and know that my inconsistency is what you need more of in society and to stand by. So today we're covering breaking news at the intersection of higher education and behavioral health. And congressional movement on federal bill designed to keep college students connected to their campus mental health providers when they cross state lines. This has been a biggie for me for multiple years now because of me doing my own research about this area. I even talked about it during my dissertation process in 2023. And what I can say is that mental health services in itself is not perfect and is created by individuals sometimes make me question if they're really in the field to help people or if they were just thrown into this field because maybe they fell in the particular area they were in. But whatever the case is, I do know that I have a foundation of loving to help people from a young age. And my biggest thing is to never cause harm to anyone. To listen and to follow through is the key. And what we're not doing a lot of as mental health professionals and leaders is listening because you're getting the information. You've had the data for years and we're still not meeting people where we are. We're still so focused on licensures and certifications that we cannot move past how to utilize the multiple providers with the education in the field. It's almost like stabbing the higher education field in the back and telling them, oh, your education isn't good enough. You're not good. You're not providing. You're not doing. And you're doing it from a large scale, but then at the same time, it's like, oh, let's throw some money over here to these higher education institutions to help them meet the needs of the population they're working with, but we're not going to give them the tools and things that they do need. To me, that's hypocritical. And hypocrisy is fine with me in the sense that it's just like inconsistencies. Hypocrisy means that you stand for one thing, but you do something different. That means that you see things from more than one lens, and that is 100% okay. That means that you're willing to navigate circumstances and situations according to the evidence and findings that you have access to. The problem I have is when we don't seek additional support to get that information on the areas that we may be missing. Now, we've seen for centuries how people are stalked and their information is gathered only to be used by these people. And they see that as a business strategy, and it's not. It's cowardism. Simple fact being is, why not just hire the person that created the idea? Then you know you have a greater success rate. But no, it's all about showing you're willing to do something different to solidify that grant funding needed by the government, only to turn around and not use it appropriately. But here today is called And this is what we're gonna talk about because it's a great act. It's an act that was created with great positive intention in mind, but a lot of times, as we learn, those things are not reciprocated positively across the field. So it's called the College Students Continuation of Mental Health Care Act. It's HR 5357 in the 119th Congress. And we translate what the bill does, the promise of pitfalls, and what campus leaders can implement now. This episode pairs the bill with recent developments on HIPAA and FERPA guidance and with peer reviewed evidence on teletherapy effectiveness for college students so you can make decisions grounded in law, policy, and outcomes. Now, here's what I have to say. We are always made to navigate around policies, procedures, right? According to the outcomes we have. But what we need to do is look at the laws and policies, reshape, reframe them because many of them are way outdated, and make them fit to where we are in society according to what research shows us. That would be the more logical thing. It would be like removing the rat race and now open it up to true possibilities. But when we stick to laws and policies, we are sticking to things sometimes that are harmful. And we all like to ask, how is mathematics utilized or important to our fields? Well, guess what? Here's a clear way of realizing how it is. Mathematics is attached to everything. Our value as human beings on this earth, our value within our job roles, our value when getting paid, it is attached to everything. Math is done. And what I like to always say, and my kids say, Mommy, I never heard this before you said it, and now it's like this big thing, but the math just isn't mathing. Okay, 2 plus 2 isn't giving us 4. All right, it's giving us like 11, 1200. And that we know that's not true if we're looking at how math is really calculated. But if you don't know how math's calculated, then you can be manipulated by the process. So, up next, I talk about what just happened and why it matters. Here's the headline. In February 2026, the American College Health Association highlighted a congressional push to allow limited licensing reciprocity so campus mental health providers can continue treating enrolled students via telehealth when those students are physically in another state, like during breaks, internships, and study away terms. I have always talked about this because it's one of the greatest things. We can try to discredit telehealth and say that the security measures and things like that, but going face to face has its confidentiality and privacy violation issues as well. So while we're here identifying constantly these negatives, let's talk about all the positives that comes with having face-to-face and telehealth-based services. Because telehealth can jump in and fit in where the face-to-face cannot. And yes, we do run the potential of more people running towards telehealth instead of just the face-to-face value. But why should it matter when it helps, right? It should be something that the face to face providers now try to learn how to incorporate telehealth into what they're doing instead of seeing it as a threat and saying, oh, no, 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 no. I'm sticking to just face to face sessions because that's what I'm comfortable with. When we get in the field of helping, we don't get in it to stay stuck where we are in comfortability. We get in it to help people and learn about the things we need to help them within ethics, morals, and those guidelines. And I see a lot of providers not doing that. And it makes you question. And they stand behind the fact that they pass an exam and other providers haven't, and that is why they should be valued more over them. Well, no, because it's the licensed people that continue to make these policies and laws that are not fitting what society needs. So the bill text confirms the core mechanism. A college mental health provider could furnish telehealth services to a covered student located in another state unless the state has affirmatively excluded the provider. Now, to me, to be excluding providers in the world we live in is just unethical and not moral. Okay, not unless that provider is out here like doing something to make people end their lives or something that causes harm to them in ways like that. And what I've learned with working with human beings is that we always like to blame someone. Typically, it is the provider. But in most of these cases, it's the individual. We cannot control another human being. We cannot even control technology. So, why are we basically holding people accountable to people outcomes overall in the basis of what they do? I could be the best therapist that's not licensed. And just because I'm placed with a patient that's chronically ill and they're not listening and they're just doing what they want to do, now that reflects me? No, it doesn't. It reflects that individual. And a system that doesn't understand that has totally lost their whole concept and reality and staying rooted in knowing what's reality versus what's not. Now, this act, it requires identity verification, acknowledgments about telehealth, backup contact methods, and real time communication for initial services. So like key guardrails against risk. Now, we can create all the guardrails we want to, but I'm here to teach you the facts. The fact is there's nothing out there that can protect you, whether it's computer based or face to face. When people have a problem and they need mental health issues and they are not being forced to do so, and they are allowed to do these things like go out here and hack systems, obtain people's information illegally. Just because I have a relationship with you, let's say for instance you're my coach, doesn't give you the right to violate my privacy. Now, going out here and searching me on the internet and finding things as face value is fine, but utilizing services like these organizations that hack people or these organizations that stalk individuals and they call it PI work. No, that is totally inappropriate. You need to sign to get that person to give you authorization to do that. Okay? Because without their authorization to do that, yes, you are breaking the law. And that's just it. And when you're looking at face to face, we cannot control who follows us or who is out here friends with whom that works wherever you're going to get your treatment. And those are all factors that violate privacy and confidentiality rights every single day. So we can create whatever guardrails we want to, but the realization of it is that any of these things can be infiltrated. Okay, at any given point. So that means that everything that you touch, everything you value and you see, doesn't come with the level of security and trust it appears to give you. It is a sales tactic, it is something used from business. And that is what you, the regular individual in society, don't understand because you don't have a business mindset. But the question is why now? Because state by state licensure rules create disruptive care gaps for students, not just students, us as human citizens across the world. It causes those care gaps that sometimes doesn't really add up, right? So it goes back to those routinely cross borders, okay? Students go across borderlines all the time to colleges and universities for whatever reason. They want to get away from family, they want a new environment, they want to have a new fresh start in life, whatever the case is. Okay. What we have to realize is that access to not just care, but services and other things should be accessible to them regardless. Because, by the way, their tuition is 2 times higher as a person that lives in state. Let's throw that out there. So, recent research in psychiatric services shows only 5% of contacted psychiatrists even knew about their state's existing exemptions or telehealth registries, contributing to broken continuity of care for students. Now, I'm a consultant. I reach out to people, organizations to try to give my service. And you know what? I'm giving back. I'm giving back the, oh, we don't need that. Oh, we got it. We understand that. But then it's like 6 months to a year later, you see that post. Oh, well, we didn't know this, or we didn't have access to that. Well, I wonder why. You're shutting down programs and services that can help you. Okay, consultant services allows you the opportunity to ask the questions or to have someone like myself do an assessment of your organization and see what those needs are and go do the scholarly peer review research and research within your state guidelines and policies and bring back to you that you can share with your legal team to validate, providing all of the links and things that you need to validate those things. Hey, we are turning down things constantly all the time to have it come out 5 or 10 years later that this is now a process when it could have been done now. And in policy circles, leading health systems argue that a continuity of care model and national registries could modernize cross state telehealth post pandemic, precisely the need that bill tries to address in higher education. Okay, let's talk about now the legal and regulatory backdrop in plain English, because apparently we use English, but it's not really English because it's not making any sense, right? So let's situate the bill in the privacy and compliance landscape you live in daily. So FERPA versus HIPAA. In schools, most student health records maintained by the institution are FERPA records, and thus excluded from HIPAA's definition of personal health information. Yet, school-based clinics run by outside cover entities may be HIPAA governed. The line matters for consent, disclosure, and crisis exceptions, and I keep saying that. We have to have consent. We need these disclosures, and we got to be able to use this crisis exceptions. One of the biggest things that I realized that I had to learn is that word of mouth can negatively impact the accessibility of a lot of things. Mostly because where I might have had a bad experience, or maybe I didn't. I just made it up because you wouldn't do what I wanted you to do. But whatever the case is that word of mouth to me is the most harmful thing to society. I should be able to look you up on the internet and see what it is that you do, your viability, what it is you stand for, and all that. Now, I can see going behind someone's back to validate things that isn't evident. But when it's evident to you that this person is who they say they are and they do what they say they do and they have accessibility to, regardless of what they create, if you can't take what's shown right there in front of your face, if you got to go and take word of mouth of people that 9 times out of 10 don't have a clue, then that right there says a lot about your sense of leadership and your sense of making decisions about the things that impact society and impact the things that are around you. All things can be manipulated. It can. So what we have to realize is that meanwhile, HIPAA itself is in flux. In 2026, the OCR signaled movement on long overdue privacy and security rule updates. So while we are basically looking at these different parts, let's look at the fact that while part two alignment here in the privacy security rule updates and reproductive health privacy changes have been legal whiplash, making it even more important for campuses to track evolving federal guidance. I need you to realize this. The bottom line is a federal telehealth pathway for campus providers will not erase FERPA HIPAA duties. Okay, it overlays them. you'll still need robust consent, minimum necessary disclosures, emergency protocols, and cross-state documentation. And I hope you guys are listening to this really well, because I see a lot of higher education institutions have these things into play, but they're not doing them. And it's including treatment plans, local resource mapping for students, physical location during care. You should be providing these new students with papers that share all accessible services that is to them, how to access them if they need them, like disability services. Like, people should understand disability services, and it shouldn't be used as a negative against them to have themselves identified to get the service they need. Do otherwise, we need to get rid of disability services and provide these things across the board, regardless of who the person is. Okay, because that is the only way you remove barriers, is to make the playing field level. And if removing something as simple as disability, if we're not going to figure out how to use it correctly, like identifying the person, not seeing them as, oh, they're just trying to get funded. No, people legitimately deserve to be identified for their disability so that they can get access to these services we're saying we put out here to help them. Through otherwise, we are basically committing fraud or scam in within the system by saying, oh, this service is here, we have availability, that it's not being utilized, or maybe it's being utilized more than we expect it to be. Well, if it's being utilized more than you expect it to be, let's figure out what's causing this and let's address that. But don't try to say that people are trying to manipulate a system that you set up. You set this system up. And if it says that having to be identified with this disability gets you this service, and this person legitimately have these symptoms and these issues going on, then take it for what it is and help the person, and not be creating things that doesn't exist. The next thing up is the case for the bill. Because when we look at mental health based services, mental health, physical health, and behavioral health are two things that can be disabling to individuals. It can cause cognitive dysfunctions to the extent where they are confused or have dizziness from medications, or maybe just processes can build up so much distress for them that they now pass out or have these symptoms that occur as a result of this physical or behavioral health factor. Now, we say mental health, but this is also related to physical health factors as well, accessibility, right? But the case for the bill is access, continuity, and outcomes. And that's why I keep talking about access, continuity, and outcomes. Because access and continuity, college students move home for breaks, internships, placements, right? They need accessibility. Licensure walls cut treatment mid-stride. The 2025 Psychiatric Services Study found awareness and wellness barriers among psychiatrists even when laws permitted cross-state continuity, underscoring the structural problem. A narrow federal reciprocity channel could reduce care interruptions. And I wrote about these in articles a year back, because it was important for people to recognize. And I saw all the impressions, but never a like, never any support, never any of that. And now we have this bill, right? And we have these things that are coming out. And that's mostly because nobody wants to truly give the true person credit when they find that person to be what they consider outside the norm or have the potential to outshine them. I'm not here to outshine anyone. I'm here to help people in society. That's what I've always been about. Even working in my field in behavioral health as an adjunct professor was helping who I was given the opportunity to help. And that's what I did. And now, whether they wanted to turn into something else because of their mob gang created mentalities, and that's what they chose to do. But I know I set the path for many. Many people watched me and went back to school and got their master's degrees. Many people watched me and went back to school and got their doctorate degrees. Never thought about any of those things before. And I'm thankful for that. And I've never wanted credit for those things. But what I've always basically thought I would get was respect. And when I reached out for the opportunity to grow, that I would be supported. But apparently, our world doesn't work that way, right? We are taught that manipulation and people that have power struggle issues are the ones that are basically setting our narrative, and that has to change. Because these great things like this right here could never be identified, utilized, and moved forward with if that was the case. Because those that still wanted to hold on to that power face to face will still be winning. We have to see that taking on new perspectives is how we grow. You wouldn't have that new car that has all that technology in it if someone stayed the same as what we drove in 1965. Okay? We would not have the clothing and the access to different forms of clothing if it was made where you just had to stick to one type of clothing. Okay? And all this stuff, we create is irrelevant. But now, back to the effectiveness of teletherapy. Multiple peer-reviewed studies suggest that teletherapy is as effective as in-person care for many conditions and populations. So, a 2022 randomized non-inferiority trial with college students receiving solution-focused brief therapy for anxiety found no difference in outcomes between video and in-person counseling. Okay? So, meta analysis across RCTs show comparable post treatment outcomes and attrition rates between synchronizing teletherapy and face to face psychotherapy. Just like that. Student satisfaction and utilization. A 2024 study in the Journal of Technology and Behavioral Science reported no significant difference in satisfaction and alliance between in person and remote service on campus, with most students viewing remote care as equally or more effective and preferring a hybrid model. So, large counseling center data sets of 205K plus students show attendance rates comparable across in-person video and hybrid modalities by 2022-2023, reflecting normalization of telehealth and student care. Now, I'm going to create a theory or a thought that maybe these students now say that they want a hybrid model because maybe they're internalizing the fact that if they say that telehealth is way better than face to face, the face to face will go away, and they don't want to see people lose their jobs. So, of course, they're going to say that, yeah, the telehealth is working just as good, if not better, but I still like the face to face. I wonder if that is the case. That's a good question out there to you guys in the professional field that like the stock to ask and see what you get from that. Because apparently you guys get the responses back, and I'm sit here to educate and provide the knowledge that you want to take and utilize. So, equity and immediacy. When costs are mitigated, interest in teletherapy surges, and one 2024 Journal of American College Health paper showed that 70% of students will use free teletherapy or self-guided supports. For rural and mobility limited students, telebehavioral care produced clinically meaningful reductions in depression and anxiety, even when improvements took a few extra weeks compared with in person. And finally, operational fit for campuses. The bills specify guardrails were identity checks, acknowledgments, backup contracts, real time initiation, mirror best practices already embedded in many campus telehealth protocols, lowering adoption friction. Now, let's take a look at this last bit of information. The case against or concern quality, safety, federalism, equity. Okay? quality and clinical safety most of the time is thrown to the back burner because to take the time to allow quality to do what they really do means that professionals have to give a little bit more of their time, and that's not billable by insurance, right? And most organizations don't get the grant funding to pay for such services, so they neglect to even have them. I know a slew of therapists right now I could call out that has absolutely zero quality processes in in what they're doing. All they're doing is seeing patients every day, doing notes and billing insurance. Okay, and when it comes time, they feel as though, oh well, I'm doing okay, I can make it, right? And when they need to apply for a grant or something like that, they're not able to. They don't have the data to support it, and they have to use national data or data from their actual area that's not specific to their organization, though. But it has some level of consistency there, and that is why they want us to continue to do the exact same things so that we can use that data from other places to support what we're doing. But I challenge you to do new approaches, research those approaches in house, have a quality team set up. I'm here. I raise my hand in support um, in that venture because it's important to have that quality and clinical safety. And the only way you get clinical safety in your specific area where you're working is by doing that clinical safety and quality there, seeing where is relevant to the patients you are seeing, to the clients you have. Okay? Because looking at what somebody else did and how it worked in their area isn't your area and isn't the people you're working with. So critics worry that interstate care could dilute local knowledge. Okay. Crisis response, civil commitment standards, and mandated reporting differing by state. So even with federal reciprocity, providers must act under the patient's location standard, which raises training and liability complexity. See, a lot of providers don't know about patient location standards. They just think that is all the same. But you got to know what's relevant to your patient's location. And that is what I preach all the time. And meeting your patients where they are and stop trying to convert them to all this national research that is there because that may not be relevant to your patients where you are. Now we got that out the way. Telehealth researchers also note that higher attrition risk in video versus telephone in some RCTs, and novice clinicians may face steeper drop off in remote care. And remote care is real tedious, mostly because you got to have reliable technology. And what we know is that technology isn't reliable. No matter what Wi Fi provider you have, it can be manipulated. What device you have, it could be manipulated through interceptions and all these various different things. And so none of it is reliable, not even face to face, because someone could have all the lights turn red when they're getting ready to go to their appointment. And we call that by coincidence. I don't believe in coincidences. I do believe in the fact that whether or not we're aligned with the universe. That's what I believe in. And when we get off alignment, yes, things do start happening that are very weird. And sometimes when we are exceptionally intact with the universe, things are happening that are very weird to try to throw you off. But what I need you guys to realize is that licensure and certifications are important. But those that don't have licensures and certifications are just as important to what they provide to the field as well. It's all about the competition spectrum or model when I was growing up in school is who can outdo who and who can convince the people otherwise. And that's what's happening in care and access. Those that have licenses and certifications are fighting against those that don't and trying to discredit them. And those that don't are trying to discredit those that are licensed. And I don't care to participate in any of that. We are all viable. We are all useful, whether we have a license or certification or not. We hold the same level of education. The only difference between someone that has a license and certification, honestly, is their ability to pass a test. And many of you didn't know that standardized tests like you take all the time, your kids take EOGs, can be manipulated. They could be given tests that are technically, as they say, compromised. and that's why they fail. Okay. Your kids could be highlighted by their last name or their name in general, and that's why they get targeted. Who knows what the case may be, but it is all possibilities and have been shown things that people can do. And some may ask, why not rely on the Psych Act by psychologists or existing medical compacts? Well, the answer is coverage is uneven, professional specific. And with this whole debate on what's considered professional and what's not, whether or not your degree will be seen as professional or unprofessional is irrelevant. Okay. Uh, Unless there's a law or something that goes into place that is incorporated in your general area, it doesn't apply. It doesn't, I mean, it's not even anything that we should be stressing ourselves with if we understand how the system we're in works. Okay. First off, the only way that we can implement things most of the time is through laws and policies. Okay. And it has to be implemented in your generalized area. Just because the federal creates it doesn't mean the state implements it. If you haven't noticed that, all states operate differently, even under the federal government. With that being said, we have to realize that many students need psychiatry and integrated teams beyond psychology. Compacts help, but they're incomplete. The bill aims to fill continuity gaps specifically for enrolled students. Now, to me, I like to provide multiple access to various different things and various different approaches, and I research them through research to see what works, what doesn't work. And sometimes I might take something that is noted in research doesn't work and actually try it just to see if it will work. And sometimes it will. And that's what drove me to realizing that a lot of these things that research shows may not be what truly works in your specific area. You have to take those particular things and do research on them yourself to see if they work in your particular area. Imagine 1 billion people, and the research that you're using is only 1,000 people, or maybe 100,000 people in total that's been researched in that particular area. That doesn't represent a large amount of our population of people. It doesn't. So, how are we utilizing that in every space, every place across the U.S.? It is unrealistic. Okay. Federalism and state authority. States guard scope of practice. The bill respects states' ability to affirmatively exclude providers, but implementation will require careful coordination to avoid preemption fights and ensure campus clinicians clearly know where they can and cannot practice on any given day. So once again, state, guard, scope of practice. That means that when you want to have something change, it is your state that changes it. It is your local government that changes it. For your county, it's your county that changes something that impacts your county, even within the state. Every county operates differently within its a state. And it's weird, it's wild, right? But it happens that way. Privacy and politicized compliance. When we look at FERPA interpretations, they have been volatile. It's including 2025 federal letters emphasizing parental inspection rights around gender identity documentation, adding pressure to record keeping and communication and telehealth across states. Institutions must prepare for audit-ready processes that withstand swings in federal oversight. Hey, we got to get smarter in this field. Many of you guys got licenses and certifications, and I wonder sometimes because, you are not doing a very good job of seeing beyond in a lot of particular areas and doing what needs to be done, state as well as county area. And I'm advocating for that because we need to see that change. We need those particular things to be seen for what they truly are. And create that access that's there. Digital divide. National surveys show that telehealth usage inequities by income, education, insurance, with video using lagging For some groups, campuses must budget for hotspots, private kiosks, and interpreter access to ensure reciprocity doesn't widen disparity. Yes, take some income and utilize it that you get, advocate or get that grant funding specifically for these particular things because it's important. And we need more funding. We need more stakeholders, people that have residual income uh, to donate to providing these level of services. You know, I did a assessment at the end of the year of a university, and I went through the whole process of the assessment, provided a very comprehensive outline on what was needed. And I will say, I was very shocked that they came back and said they didn't have the money, even with me decreasing it down, right? That shows the level of manipulation and things that people will do, right, to processes and when you're trying to help. They will even go to creating things around why. Now, the other reason they're not taking you, oh, you're not seen enough, oh, you're not known enough, oh, you're this or that part. Okay. All those are excuses. Okay. Any new invention didn't have supporters, it took someone to support it. Okay. What the bill actually requires of providers. If enacted as introduced, here are the practical checkpoints drawn from the bill text. First, verify student identity before telehealth. Obtain telehealth acknowledgments and retain records. Collect multiple contact methods to manage tech failures. Use real-time interactive tech when establishing new treatment relationships. Respect state exclusions. If a state bar practice, reciprocity doesn't apply. So these align with many campus telehealth playbooks and are compatible with FERPA HIPAA documentation standards when paired with clear consent and emergency protocols. Evidence Roundtable, peer-reviewed insights. Let's talk about this. Here's the host. Teletherapy versus in person. Non inferior outcomes for college anxiety treatment randomized trial. Meta analysis across RCTs, synchronous teletherapy in person on outcomes and actuation, training, delivery needs support. And student satisfaction, that's the next one. Okay. No significant difference, hybrid preferred. Large campus datasets, attendance comparable across modalities by 2022-2023. And I have to go back and say this. If I'm someone that doesn't want to see something get shut down or stop, I'm going to incorporate it in it. And I like how we say hybrid is preferred. Why not say that telehealth is really preferred? It still doesn't discredit that face to face doesn't work or that it's not viable. Those are the questions we have to ask ourselves. Why are we so defensive? Rural impact. Telebehavioral care reduces the PHQ-9 and GAD-7 to subclinical ranges over time. And provider readiness. Training matters. Students and trainees can build telepsychology competence with structured curricula. And policy bottleneck. Cross-state licensures remains the core barrier despite compact and exemptions. Did you know that many of the professionals in leadership in higher education are less likely to get the care they need, whether consulting, coaching, or therapy, because of how it may make them be seen? Hey, I'm not out of seeing any more higher education individuals feeling like they have to move in silence and then ending up taking their lives or ending up harming the people that are around them that truly love them as a result of them not feeling as though they can seek the help and care they need. When you've been through a stressful task on the workplace, job. Maybe you're working on a grant. Maybe you're working on a project. Maybe you're working on producing better systems and workflows. You need support and help. Why not get it? Help alleviate some of the stresses there. Because the more stress we take on, the more it manifests itself in our body. And most of the time, we get headaches, stomach aches, and all these pains as an association of our body not functioning like it needs to. Let's take a look at this last segment, you guys. Action checklist for higher education and behavioral health teams. This is what you've been waiting for. So if you're a VP Student Affairs Counseling Director or Integrated Care Lead, here's your 90-day sprint while Congress deliberates. First, map your cross-state risk. Quantify how many active students are receiving care from a campus provider while physically located out of state in the past year. Project, peak flows, and breaks in internships. See the value in having virtual-based professionals, someone that can be accessible to you when you need it. You don't have to wait for them to fly in. You don't have to wait for them to relocate. You don't have to wait for them to just pop up in your office. All you got to do is click a button on your computer and there they are. Send an email or a text response and there they are. The next thing is update telehealth SOPs to reflect identity verification. Make sure that they are providing their student identification as well as their state identification. Multiple contact methods, emergency geolocation workflows, FERPA versus HIPAA decision trees, and documentation templates to capture telehealth acknowledgments. Next, build local resource grids for top destination states, hotlines, emergency departments, mobile crisis services aligned to the patient's location standard of care. Train providers and trainees on cross-state practice rules, clinical safety and telehealth, and handoffs. And the next one is budget for equity. Privacy telehealth rooms, connectivity support, interpreters, and synchronized follow-ups for students with limited bandwidths. And finally, track parallel pathways. PsychPack for psychologists, state telehealth registries for physicians, or they're available if you need them. I understand the concept of working independently, seeking what you need yourself. I get it. But if what you're doing isn't working, if what you're doing isn't alleviating stress, it's adding stress, then you need to reevaluate your process and those things. So in closing today, the College Students Continuation of Mental Health Care Act is a part of a broader reengineering of access for young adults whose lives naturally cross borders. Whether or not this exact bill becomes law, the signal is clear: continuity matters. And the evidence says telehealth can deliver when supported by training, equity investments, and robust privacy practices. If you want the reference sources and a one-pager checklist tailored to your campus network design, message me and I'll send the PDF. Until next time, I'm Dr. Taranda Knight. Stay rooted. Never feed the beast, never fed the beast. Work hard and stay peaceful, because we're here to build roots of resilience. Go ahead and get a copy of my book, The Plant of Leadership. It is cultivating the ethics and the ethical growth in times of adversity. So get that copy. You can go straight through my website if you are questionable of the validity of online sites, or you could just go to Amazon and type in the name of the book, The Plant of Leadership, Cultivating Ethical Growth in Times of Adversity, and purchase your copy today. So, you guys be great, be wonderful. Until next time.